They said the first slide should be a biography, but I think I'm quite boring. I thought I'd tell you about my teachers and people who influenced me instead. Dr. Petrosi was our emeritus when I was a medicine resident, and he'd always go to the library and read every day after rounds. Michael Andery was my HOD at Michigan State University for PMR, and he'd keep on saying, do a good job every day. I didn't understand what it meant until I started working with people who didn't do that. When I came to India, I met Suranjan sir in his last 2 weeks at CNC Vellore, and even as he was leaving, he was learning how to do peg tubes and wound vacs for patients just to make their life easier. It was really impressive to see that. I later went to Japan to learn spasticity surgery from Takomi Taira, who actually is a pioneer for all ultrasound-guided destruction lesions in the brain. That was more than a decade ago. But when you start learning all these weird things, you start getting weirder patients, and eventually to learn something like neural therapy to deal with psychosomatization with patients. Last year, this guy said something really interesting. He said, you know, why should you do something that 5% of the population needs, do what everyone needs, and do it really well? And that really stuck with me. So I want to show you something you should all know about, and why you should know about it, and artificial intelligence. So when you finish your degree and you go into the world and you look to get a job, people will tell you, we want the best rehabilitation department here. And everything looks like a candy store. There's robots, there's artificial intelligence, there's this and that. What do you get, right? No, sorry, just a second. The reality is, if you want to survive in medicine, you need to do a good history, a good exam, and learn differential diagnoses. That is always the basis of it. The technology is just fluff on the top. The problems we have with PMR in India, I think you guys, if you don't already know, you're going to learn it soon. We have people who don't know what we do, but they know what we should. They know the need for us, therapists posing as doctors. There's no homogeneity within us, right? I'm not even a surgeon. I don't cut. I'm a physician, right? Yeah. Oh, I think it is working. Yeah. So rehab requires a team approach, so it can't just be you doing all the right things. And there's a lot of time and cost to get the right setup going. And nothing we have as PMR makes us a discrete entity. Anyone can do what we do. They steal from what we do. So it becomes a problem, right? The big problem is people don't really know what they should do with the patient when all these important investigations are done. They should come to us, but most doctors don't know who we are, what we do. Lots of problems in PMR, right? Sometimes being in PMR in India feels like this, being attacked on all sides. It's kind of annoying. It's not all the time, but sometimes it can feel like that, right? So where there are so many problems, there are solutions like AI, and AI works because it can make accessible care and more effective care, and I'm going to show you how. What is AI? It's computer systems that do tasks, not the job, tasks, normally done by people. How? By using data. What data? Haptic data, video data, audio data, electrophysiology, inertia measuring units, patient-reported outcomes, biochemical event, all those different data points it can use to help you make a decision. What is AI good for? What it really does is it shows you unknown associations and patterns, things that we miss because we can't process too much at a time. It can help you compare large data sets. You can integrate multiple variables to make precise decisions. So when you get to the exam, paper 4 will be the new technology, and this might come in there. When it comes in, it's going to say, enumerate the indications for AI, or the uses of AI in physical medicine rehabilitation. And we're going to talk about this in 4 headings. So overall, you can have an AI that does a chatbot function for you. The most common questions people ask, you'll start learning what they are, and you can have a chatbot ready to answer those questions so you're not wasting your time, or you can filter out what really needs to be answered. Another thing is, you can actually start predicting how a person's going to respond to rehab based on a plethora of different variables. They came at this age, this gender, this far from what, and how they came, and how they should expect to improve. You can improve your diagnosis by using imaging analysis. So AI starts picking out things that human eyes miss. Right? You can even have natural language processing. So a patient can give you an entire WhatsApp message, you run it through the AI, and it starts picking out the relevant history points that you need to make a diagnosis and treatment. So you can call the person and say, you should just take a paracetamol can call me in the morning. Come in now, we should treat you now. That's how these things work. So you can use it for virtual rehabilitation. I'm going to show you some of those soon. But you can also make a personalized treatment plan. A lot of the times we have a particular prescription. This diagnosis equals this many drugs, and we modify based on patient conditions. But here, we're looking at a person on a very intimate level, and you can make a plan for them on that way. You can also get bombarded with data and patient monitoring and early intervention. You can have all these sensors feeding you information. It's a bit annoying, but there is a value for it. I'll show you that. So let's look at particular things, prosthetic and amputee rehabilitation. You can have automated and personalized care. You may not need a technician if you can have a CAD/CAM machine do all these things for you. A simple scanner will get the images and the measurements you need. The machine can scan it for you, make the modifications as required. Right? We do a lot of bionic hands where I work, right? So there are AI chips in the hand that will learn how a person activates the sensors to get you different grip patterns. Just the same, you can even give sensory feedback through targeted muscle reinnervation. This is one of our ongoing projects right now. Right? You can even analyze gait through all the different variables together in ways we haven't seen yet. Right? The other thing is communicating with all your patients together as a group, telerehabilitation. When we look at personalized pain management, things are a bit different. Pain occurs in so many different levels, it's processed in different ways, and manifests in different ways. There's actually a study right now that shows you can predict future pain using artificial intelligence. All these AI-powered wearables, they can give you feedback as to you're sitting wrong, you're not sitting straight. It can give you feedback as to straighten yourself up to prevent further pain. We can use AI to distract people from getting pain when they're going through procedures. You can even use this for cognitive behavioral therapy remotely, where you can start working on people to modify their behavior. And then natural language processing, again, for pain assessment. What is that person's words they use to describe pain? What does it mean to them? Because we all describe pain differently, interpret it differently. So then adherence and monitoring can be tracked with an AI. Analyzing treatment efficacy can be tracked, and then neurorehabilitation. So virtual reality and augmented reality. We've seen a lot of AI studies come out using this to see how you can track movement, track progress. Again, robots that will go into therapy to perform and reduce the number of work a therapist should do. The robot can do it for you, but it can have sensors in that say, don't push too hard, push a little harder, like that, right? And then brain-computer interfaces, which are still in the works. This is an interesting study. I don't know if any of you heard of Pretzel. Pretzel is a neonatologist from the 1980s who started watching babies that were born, and he started seeing some develop cerebral palsy, some develop autism, some develop OCD, etc. And he started watching newborns in nursery to see who was getting that, and he started finding babies that don't develop in a particular way end up having these symptoms. So he started video recording them. And he made a Pretzel scoring score, the GMA, gross motor assessment. And essentially, neonates will move a little bit. They'll have kind of fidgety movements, then they get writhing movements, and then they get the full coordinated movements that we see in babies as they start to mature. The ones with CP don't do that. The ones with OCD and autism don't do that, right? So this is a new publication in Nature as of last year, where they used an AI to do this. And now you can just put a camera over any baby in any nursery anywhere in the world and diagnose OCD, cerebral palsy, before it's even diagnosed. Because we wait till the age of 2 to make that diagnosis right now. It's quite a problem. So predictive analytics, cognitive rehabilitation, telerehabilitation, remote monitoring, speech and language therapy, continuous monitoring and feedback. That is the extent of what's going to come in your exam. As long as you remember those points, you can be creative and write down what you want. It won't really be wrong. The problem is AI is really coming up, and it's going to be in future conferences. So you'll have someone say, hey, my AI said this, right? And what it said was right, maybe it's wrong. The AI is not perfect. It's for us to interpret it, right? But the AI could say something you've never seen before, and does it really mean anything or not? That's for us to decide, right? You'll have people who say, I've been saying that for years, but they won't have the publications or data to actually prove it. This is how you actually prove these things, right? And there's other people who are terrified. It's the end of the world. The machines are taking over, right? But it's not really like that. Life is going to keep going on. Just if we don't get involved in these things, they'll go out of our hand and we won't have a place in. So AI is here for your tasks, not your job, and it can help you be a better version of yourself. Integration with AI is happening quite fast. It took 250 years to get electricity and make computers from there. 45 years to get computers to AI as we know it. 62 years to get 50 million users for a thing like a car we all take for granted. But it only took 2 months to get 100 million users for ChatGPT. So this is how fast integration is happening. As long as technology keeps growing, this will keep happening. The problem is when you talk to doctors, they don't believe in AI. And many are against it. They think it's stupid, it's a hoax, whatever else. So they don't listen. And this is why we talk about these things, right? So how do you get a doctor to listen? You show them the happy doctor who has AI and the sad doctor who doesn't have it. And then they think, oh, I can do that too. I'm a big boy. I can shave also, right? So the question is, who am I to talk about AI, right? And the answer is, I published a systematic review on artificial intelligence in diagnosing pain. It's in PubMed, you can see it. We even made an artificial intelligence telemetry device. And it sits on your chest, it feeds your ECG into the cloud, so remotely we can track their ECG as they do exercise for cardiac rehab. We have a study going with pediatric cardiology right now for that. We had a hackathon for artificial intelligence and stroke rehabilitation. That was our first one last year. Here's our second one, artificial intelligence and nutrition. So we have an AI that generates a diet plan for people with very specific conditions, stroke, inflammatory bowel disease, etc. But it gives them an exact diet plan. So we tell people, don't eat this, do eat that. Here's a diet plan, which is much more precise, right? This is a study we just completed. It's going to publication soon. We wanted to see if AI could identify normal and abnormal gait in children with problems. So the clinician knows there's a problem, but we're going to see if the AI can be trained to do that. So it's a cross-sectional design. It was from home and hospital-based patients, and we got kids from pediatrics who were normal, kids from pediatric neurology who were not, right? And we got informed consent, and the parents took videos of these kids, right? And then each video was 15 to 30 seconds, and the child walks for 20 feet in a straight line without any assistive devices, and everything is stored in a HIPAA-compliant wrist server, and AI will then say normal or not normal. So we got children between the age of 4 to 7, GMCS 1, 2, and 3, and they should not have had concomitant neurological orthopedic conditions. So this is a lot of tech and AI mumbo-jumbo kind of talk. Essentially what it's saying is this AI will take 16 frames per second from the video. It'll identify what it thinks is important, and it'll say normal or abnormal based on that. When you start cutting 16 frames per second, you're going to have a lot of data fragmentation. So what you're seeing is how we prevented the data fragmentation and preserved the integrity of the data. So essentially, we had to take 80% of our data to train, and we took 20% to test it. And then from there, we got about an 80% accuracy, 82% accuracy that where this could actually sort out normal versus abnormal. So AI can be used to differentiate normal from abnormal gait using a cell phone video with 82% accuracy. And this means you can take it to the villages where parents don't know or don't know if they should stop work to come meet a doctor to get a workup. They know the kid's not walking normally. They don't know if they should wait or not, right? And this could be used to set up a referral chain. So we're kind of getting into what AI is in the bigger picture. And we've had a lot of ages of medical knowledge. We haven't seen this age, but it was the age of wonder, where there's anecdotal evidence, exploration, serendipity, and it was like a buffet. You can have whatever you want, right? There was no books around in that time. So those guys, they came and started codifying all the knowledge. And you can start seeing the textbooks come in, Harrison's, Cunningham, Bailey and Love, right? And there's conferences, there's forums, then eventually it evolves into EBM, right? But now you have franchises. So you have different schools of thought for every discipline and particular thought processes approaching healthcare. But this is where the books came in, right? And then we got scanners, so everybody can have a book. We had one of our professors, George Joseph, hand copy Kendall because he didn't have a way to get the book. But now you can scan it, right? And then Google came, and Google put everything on the internet in PDFs, not just for doctors, for everybody, right? And then it went into the phone, and no one reads the books again, right? But we've reached this age of misinformation, and this age of misinformation is where there's widespread dissemination of lies within truth. There's a lot of propaganda, and no one knows what's really true anymore, right? People are being overfed with trash. Like Sanjay sir was saying, you don't need to read 50 books. You take one book, you attach it to the patients you've seen, you develop your own knowledge base, right? But a lot of people have gone far from that because there's so much to read. What do you read, right? This is the AI apocalypse. The AI apocalypse promises, we have to see, it promises to change things. AI is going to show us things we don't know, right? And what that means is going to take all the existing knowledge and make it into a baseline, where now you're a doctor, you have this degree, and here's an expert system that will show you what you should do in every single case. So you don't have a variability in the baseline where there's good doctor, bad doctor. You have a standard doctor, and then from there you have the sky's limit. Whoever wants to can develop further along those lines. Standardization. That's what AI promises for us in healthcare. The problem is, again, doctors don't believe this. And we come from this parampara, or tradition, where you have your teacher, you listen to what your teacher says, and you learn, right? And then the books come in, but you go back to your teacher, you see what they say, and you believe what you want to, but you're going back to a person, right? Evidence-based medicine comes in, your teacher agrees, doesn't agree, they tell you why, but you go back to your teacher again, right? We even have this plug-in and play now. You can go to a chatbot. I make my students go to a chatbot in class, get information, right? But you still go back to a teacher and you learn, right? This is what we do in modern medicine. Engineering is that. How to learn from a failed experiment. And they learn left and right by making mistakes, but there's no human life involved. That's the thing, right? We're in trouble if we make a mistake. Someone's going to die, someone's going to get hurt. They can mess up whatever they want. It's physical science, right? This is the clash we have with doctors and artificial intelligence, right? So essentially you have a human expert, the doctor. You have a knowledge engineer who's going to compile all that information. They're going to make a knowledge base, an inference engine, a user interface, and this makes an expert system. So you could have a cardiology expert system with all the cardiac knowledge compiled into one thing that helps make decisions based on what you give it, right? And this can go into the hands of a future doctor. So it's always been doctor goes to the patient, right? But now this doctor in the future is going to go with an AI in his little computer, right? And so we come to days of future past. And in the days of future past, the doctor goes to the patient. It's happening again. We're going back to patients' houses to meet them again rather than a hospital, right? But in the old days, that's how things started. You go to the patients at their home, barefoot doctor, see people in the village, no big name, no fancy procedures, just good care, right? We started seeing that there's really bad cases that should be isolated and put into a place where they can be treated more aggressive, like a hospital. Hospitals started popping up left and right. And then we realized we need doctors without borders, because there's people who are still being missed despite having hospitals. They can't afford, they can't reach, whatever else, right? And then came the pandemic, so we have telehealth, right? And telehealth means they can stay at home and you can counsel them and triage them from home. Come in, don't come in, take a paracetamol, get to the emergency room now. We're coming back to this model again. And what it looks like is a future where we're going to have either doctors who reject AI and reject technology, and they just use bare standard technology, which is not a problem, or you have doctors who are empowered by AI, right? And which is going to become mainstream in India, I don't know. It's anyone's guess. I assume it's going to be half and half, right? But this is what we're headed towards. AI has been called the great equalizer. I want to show you why. So once upon a time, it was just doctors, right? And doctors treat people. And then we had specialists, because there's doctors who want to learn more about a condition. And specialists don't treat people. They treat organ systems, rheumatology, neurology, neurosurgery. I'm not making fun of our colleagues, but that's what happens, right? But that's not enough sometimes, right? You learn more, and then you have subspecialists. And subspecialists, they don't treat organ systems or people. They treat specific diseases. That's how they have big, big names, right? But from here, what happens is, what happened to that person, right? Functional neurological disease, get him out of here, right? So the AI apocalypse promises to close that knowledge deficit, standardize the baseline, right? So that anyone can practice at these things. And what that leaves us as doctors is with doctors who have an expert system in their hand that can tell you what to do based on the existing knowledge so far. It might be wrong, but it's for you to decide. But that leaves us as doctors who work on prevention, doctors who work on treatment, doctors who work on rehabilitation, doctors who work on palliation, right? But you have an expert system to guide you with all the existing knowledge, and you learn from there, and you can add into and contribute. Is that the truth? Is AI the great equalizer, or is it a hoax? And that is AI, it was told to make a face. That's the face. So people say AI is a hoax, it's hit its peak, it's never going to grow any further, it's just the next tech scam. The truth is somewhere between these two things, and which one it is, we're going to show it. The hard part about healthcare is always reality is harsh. We have a fiduciary duty. We are expected to give a patient a benefit. They come to us, we have to give them a benefit. They should get better, right? So the analogy is a car, right? And the car is healthcare. And the passenger, blah, 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 blah. AI is good, AI is bad. I don't know what AI is. Public opinion, administration, patients. That's what they're going to keep doing. They're our passengers, right? We're blindfolded. We don't know where AI is going, right? People keep saying they're going to take all the brakes off AI and let it go full, but they don't know what can go wrong, right? So we're told to get on AI, and that's the gas pedal. If you're from the gas pedal with your blindfold, you could hit something in 5 seconds, you could hit it in 5 years. We don't know when we're going to hit problems, right? So the gas pedal is AI, and the problem with all these engineers is they don't know what the brake looks like. They have no idea what can go wrong. But it can be video data that gets leaked in the internet as a deep fake, and you can lose all your money. Or you can be in prison for something you never did, right? This is a real concern with things like AI. The other part is this. The AI takes no responsibility, clinically correlate. So the AI has said this is the diagnosis, but if the doctor doesn't agree, let's see what happens. We have undesirable health outcomes in healthcare, right? This happens all the time. You do the right thing for the right patient, you get the wrong outcomes. So let's look at what happens when you add AI. So doctor is the point of care, patient comes to a doctor. Doctor does what doctor does, get the lab, get radiology, make a decision, and if there's an undesirable outcome, patient curses doctor. Nothing new, we've all seen this before, right? So what happens when doctor consults AI and they still have an undesirable outcome? Same thing, same story, right? Nothing new. What happens when AI becomes the point of care? Who told you to go ask the AI, you stupid? This is what it is. They are independently asking a machine to make a decision on them when there's no one involved. So the only person they can blame is themselves, right? And again, if the AI consults another AI to make a decision, the person's the person asking for all this information. It's their problem, right? No one's that dumb. They're going to get us involved, like Dr. Google asking us books and books of information, arguing with it. That's their problem. But if you don't know how these things work, where they go wrong, you're out of the game. So the thing is, anything measurable is data. Data can be put into a database. That can be made into artificial intelligence, machine learning algorithms, and that is money, it's power, it's survival. The dirty truth, right? The implications are, if you use AI, it can give you more time to spend with patients. A lot of the basic triage can be done for you. There's currently a battle of who's the most popular, who's the most skilled, but it can become that of the most compassionate instead. Who spends time with the person to actually listen to what's going on? The AI will sort out things from the ground, but it's for you to be a human to another human. Again, it's not the strongest of the species that survives, nor the most intelligent. It's the one most adaptable to change. So some people say, hey, what do I need to do to get started? I'm kind of interested now, right? You need to have patience. You're doctors, you should have it. You should have a computer. You need a comma-separated variable or an Excel sheet. You probably used that before. Time, a programmer, and they should be able to help figure out what AI you should be using, and then a clinician to interpret what the AI puts on and see if it actually makes sense or not. I think the bottom line is when we say these things, people wonder, am I going to get made fun of? And you aren't doing it wrong if no one knows what you're doing. So if you're using AI and they can't figure out, that's their problem. If you know what you're doing, that's enough. Done.